Welcome back. In today's video, we are going to discuss about the various types of intrauterine devices. The objectives of this session is to understand the types of intrauterine devices. We have medicated and non-medicated. The IUDs, the classification of IUDs is as follows. We see that we have 3 generations of IUDs in total. The first one is non-medicated. The non-medicated is the first generation IUD. Non-medicated is first generation. We see the non-medicated is first generation. Under the medicated, we have they release either the metal ions like copper, or they release the hormones such as progestogens. Okay, hormones such as progestogens. In this, the medicated, the copper is known as the copper IUDs are known as second generation IUDs. That is, the metal ions, they are the second generation, whereas the hormones are the third generation. Clear, guys? Let us revise again. The IUDs have been classified into medicated and non-medicated. Non-medicated is known as inert, or it is non-medicated or inert. They are the first generation IUDs. Under the medicated, we have two. One releasing the metal ions like copper, and the hormones such as progestogens. In that, copper belongs to the second generation and hormones belong to the third generation. I hope all the 3 generations and their classification is all clear. Now let us understand each of them in detail, starting with the non-medicated intrauterine devices, which are first generation IUDs. There are 2 subtypes in that. One is Lippis loop and the other one is Grafenberg's ring. What is it? Grafenberg's ring. Okay, we have Lippis loop and Grafenberg's rings. Under the medicated or bioactive, now we see under medicated or bioactive, we have metal ions. Under metal ions, we have earlier devices and newer devices. Okay, guys, now let us understand. The first one is all clear. Non-medicated or inert or first generation, Lippis loop and Grafenberg's. We can see Grafenberg's here, and Lippis loop, it is double S shaped. In detail when we study, you will understand. Okay, double S shape, this is Lippis loop, and we have rings, those are Grafenberg's rings. Each of them will discuss. Now that time you can see all the pictures, all clear pictures. Now for now, just the classification, the gross classification, we see that. Now we are moving on to the second half, that is the medicated IUDs or bioactive IUDs, that is second generation. Under the metal ions, we see that under metal ions we have earlier device and newer device. Earlier devices and newer devices. Under earlier device, we have copper 7 and copper T200. Copper 7 and copper T200. Now moving on to the newer devices. Let us see. Earlier devices, remember guys, number 7 and copper T200. Moving on to the newer devices. In the newer devices, they are the variants of T device. Under the variants of T device, we have copper T220B and copper T380A. Okay, these B and A refers to the specific sizes. So we see that 220 and 380. These are the variants of T device. Copper T, because they are the variants of T devices. Then in the second newer device, we have Nova T, which is composed of a silver core. We have Nova T. Okay guys, Nova T. The third one are the multi-load devices. In the multi-load, we have multi-load copper 250, multi-load copper 375. Multi-load copper 250 and 375. So now let us like summarize all the numbers. Okay, the first one under the earlier devices and newer devices, 7 and copper T200. In the newer devices, this Nova T is like clear. Okay, this is separate. Nova T silver core is separate. Now we have variants of T device and multi-load devices. Under variants of T device, what will you remember guys? 200 is done, 220 and 380. and the multi-load devices we have 250 and 375. Clear guys? The numbers you have to remember, 220 and 380. Under multi-load we have 250 and 375. 380, 375, 220, 250. I hope it's clear. Now we are moving on to the hormonal. Under the hormonal we have the hormone releasing IUDs. That is the third generation IUD. We have progestosert and LNG-20, also known as Mirena. Levonorgestrel 20 is also known as Mirena. And we have progestosert and LNG-20 or Mirena. I hope the classification is all clear. Now let us move on to each of them in detail. Starting with the non-medicated or inert IUD of the first generation, we have Lippes loop. What is it guys? Non-medicated, two were there. One was Lippes loop. The other one we saw was Grafenberg's ring. Now let us start with Lippes loop. Lippes loop is a double S-shaped device made up of polythene. So we see that it is a double S-shaped device. You can see the double S-shaped device. Okay. We are starting with the first one, that is the non-medicated or inert IUDs. They are the first generation IUDs, and in that Lippes loop, which is a double S-shaped device which is made up of polythene. Polythene, a plastic material. Why is it made up of polythene? Because it is a plastic material. It is non-toxic, non-tissue reactive. We see that these Lippes loops are non-tissue reactive. They do not initiate any chemical reactions or cellular reactions in the body. And they are extremely durable until and unless it's displaced on its own or removed when desired, it stays in place. It is extremely durable device. Now we see that it contains barium sulfate to allow the X-ray observation. Now these are the X-ray pictures wherein you can clearly make out the double S shape. Can you guys see? The Lippes loop clearly we can make out in the X-ray. The loop will contain the small amounts of barium sulfate. Because of the presence of the barium sulfate, you can easily observe it in the X-rays. Failure rates. Okay, the four sizes are available: A, B, C and D. The sizes, various sizes they have given. A, B, C, D indicates the sizes. The failure rate of Lippes loop is 3%. Highest pregnancy rates and highest expulsion rates are seen. It is durable, but we see that there is a highest pregnancy rate. That is, failure rate is high, and also the expulsion, spontaneous expulsion is also very high in Lippes loop. The lifespan of Lippes loop as long as it is required, because it has no adverse effects, right? So the tail, like you can we see that the tail, once you start feeling it displaced from its place, and then we remove whenever we desire it. So now let us understand something more in detail about Lippes loop. This Lippes loop will have attached threads. So you can see guys, these attached threads here. This loop will have the attached threads or the tail. This tail will be made up of nylon, and you can tail you can project into the vagina after the insertion. This tail will be easily felt, and because of the presence of the tail in the vagina, it shows that the loop is still present in place. The tail will also make it very easy for the loop to be removed whenever we desire it. So we see that the presence of this tail will help us to know that the Lippes loop is in place, and whenever we require to remove this Lippes loop from the vagina or the uterus, what do? We just pull out the tail. So we have also understand the mechanism and everything, how it is placed. Now let us move on to the other thing, that is Grafenberg's ring. In the Grafenberg's ring, the picture have been given here. You can see how the Grafenberg's ring, how it is inserted into the uterus, and the ring, it also contains the barium sulfate. So you can observe this ring inside the like X-rays, you can observe it. So I hope it's clear, guys. The non-medicated IUDs. Moving on to the medicated or bioactive IUDs. Under the bioactive IUDs, we have metal ions, that is copper of the second generation. We saw the earlier devices were copper 7 and copper T200. The failure rate of these is 3%. So we see that the older devices, earlier devices or the older devices, the copper 7 and copper T200 failure rates we saw were high, that is 3%. Now what happened actually was, initially they had non-medicated IUDs. Since this copper is containing some strong anti-fertility effect, they started adding this metallic copper to the intrauterine devices. A new approach was made, a new trend they bought in to add copper in the IUD because of the anti-fertility effect. This made the IUDs a very common and widely used contraceptive device. And also this copper T has many advantages. The expulsion rates are quite less, and the incidence of side effects like the pain and the bleeding is also very less in comparative to the other things. Moving on to the newer devices, some more advantages we will deal when we finish the newer devices and everything. Now let us confine ourselves to the classification. In the classification, the first one is done, that is copper T7, copper 7 and copper T200. By now we are very well versed with the numbers. Moving on to the newer devices. Under the newer devices, that is variant of T device, we have copper T220B. What does this B indicate? So under the newer devices, 220 and the other number, guys, what did we see? 220 and 380, right? So let us see copper T, 380. So copper T 220, the B will stand for the size. And now we have copper T 380A. What does this A indicate? The A in this indicates the Ag of the silver and Au of the gold. The failure rate of this newer device, from 3%, the newer device, the rate is directly falling to 0.5% to 0.8%. Can you see the change, guys? The failure rate has come down. The lifespan of this copper Ts is 10 years. So we see that the copper's the lifespan will be 10 years. From 2002, the National Family Welfare Program in India has started using copper T380A. What is the reason? Why did the National Family Welfare Program in India go for copper T380A? What was the reason, guys? It is because the high efficacy of copper T380, long acting, 10 years it provides contraceptive effect, and the expulsion rates are very low. Because of this advantages, they adapted copper T380. We have Nova T, which contains a silver core. It is used for 5 years. And then we also have the multi-load devices now. Under the multi-load devices, we have multi-load copper 250, multi-load copper 375. Okay, guys, multi-load copper 250 and 375. Here we saw 220 and 380. Then, guys, 220, 250, 380, 375. By now we are perfect with the numbers. So now it is done. Copper has a anti-fertility effect. The numbers will refer to the square area in the square millimeters of the copper on the device. So we see that what does this number refer? Why have they told copper T220, copper T380, copper T375? This 375, 220 and all these refers to the area. The area of which the surface area, which is given in square mm of the copper on the device. How much copper is on the device? So we can see that the picture of all of these now. The copper 7, you can see it's just in the shape of 7. And we have copper T200. In copper T200, we have one horizontal arm and one vertical arm, wherein the copper is present here on one hand, and here in copper T220B, in the newer devices, both the arms the copper has been present, and copper T380, both the arms there is copper. very easily you can differentiate if there are spotters in the exam. Copper 7, if they have kept, you can write down copper 7 is an earlier device. You just by the copper 7 only you can make out this, the IUD represents the number 7. Okay, so we are done with medicated. Moving on to Gynafix. Gynafix is a new frameless IUD. It's a new frameless IUD. Some more advantages I forgot to mention about this medicated IUDs. The advantages of these copper IUDs, like we saw, the expulsion rates are very low. Side effects like pain, bleeding is comparatively less. It is very easy to fit. Even in the nulliparous women, these IUDs are very easy to fit. They will be well tolerated by the nulliparous women. The contraceptive effectiveness is very high. We see that because of its high anti-fertility effect, the contraceptive effectiveness, that is pregnancy occurrence, will be very low. The woman, once she chooses or desires for the copper T IUD, the rate of pregnancy in such women who are using copper teas are very less. It is effective also in the as a post-coital contraceptive. If it is inserted just within 3 to 5 days of the unprotected sexual intercourse, there is a possibility that it can act, not possibility, it is very effective as a post-coital contraceptive. Moving on to the Gynaflex. Gynaflex is a new frameless IUD. You can see that it's just a very frameless IUD. 4 to 6 copper tubes together are fixed with a thread. So you can see here 1, 2, 3, 4, and here 1, 2, 3, 4, 5, 6. 4 to 6 copper tubes are tied together with a thread. You can see a thread here and 4 to 6 copper tubes. Gynaflex 200 will contain 4 tubes. Gynaflex 330 will contain 6 tubes. They are embedded into the myometrium. You can see they are completely, it is entering into the myometrium. Okay, myometrium. And that is the fundus of the, in the fundus it is entering in the myometrium. It is suitable for the nulliparous women. You can just see here this Gynaflex, the picture of the Gynaflex, the copper tube 6 and copper tube 4 and a thread, and using this they are embedding it into the myometrium. This is all about Gynaflex. Moving on to Gynafix, and now we are moving on to hormones, that is the third generation IUDs. In the hormones we have progestogens, which is the third generation hormones or progestogens. In that we have progestocert and LNG, levonorgestrel 20 or Mirena. Starting with progestocert, it is a T-shaped device. So we can see that it is T-shaped. It is T-shaped, and inside it will be loaded with hormones. 38 mg progesterone, which is the loading dose, than 65 mcg daily. So we can see that they release 65 mcg of the hormone daily. In the progestocert, we see that it is loaded with hormones and it is a T-shaped device which releases 65 mcg of the hormones daily. The first hormonal uterine device which was developed in 1976. It was the first hormonal device. So far we saw non-medicated or inert. We also saw the metal ion releasing, we had copper teas, multi-loads. Now in 1976 the first hormone releasing one was this progestocert. The failure rate is 1.5%, the lowest expulsion rate and the lowest removal rate. So these are not these are all the PG questions, okay, like PG entrance exam, pre-PG questions. What are all those? This underline 38 mg of progesterone, loading dose, how much does it secrete daily? 65 mcgs it secretes daily in the body. And also, which is the first hormonal uterine device? Hormonal. When they ask the hormonal device, go for progestocert. When was it developed is not important. Which is the first hormonal uterine device, guys? It was progestocert. And the lowest expulsion rate, lowest removal rate is that of the progestocert. The lifespan of progestocert is very less, that is just 1 year. Whereas we see that in copper T3, A and all, we had 10 years of contraceptive effect. and in multi-load devices we had 5 years. They are effective lifespan of at least 5 years in multi-load devices, whereas here we just have the lifespan of 1 year. Whereas in LNG-20 or Mirena, which is also a T-shaped device, it contains 52 mg of levonorgestrel. LNG stands for levonorgestrel, and it releases 20 mcg daily. So you can see that it is releasing 20 mcg daily. The failure rate is just 0.2%, but the removal rate is high. The pregnancy rates are very low. The failure rate or the pregnancy, once the contraceptive fails, pregnancy occurs, but in here once the failure rate is very less, the pregnancy chances are very low. Also guys, you see here the difference in cases of progesterone, the device is T-shaped. Here it is slightly hooked shape. Okay, you can see slight hook here. This is also T frame, but the frame is slightly bent. It is LNG-20. 32 mg LNG-20, or also known as Mirena. It also has threads for the removal. It will be inserted into the uterus, and this threads will be in the vagina. Whenever the removal is desired, these threads are pulled out and the device is also removed. So now we are done with the various types of intrauterine devices. Guys, we studied about Lippes loop, this S-shaped device, Grafenberg's ring, which is the ring we saw the picture, and then medicated or bioactive, in which earlier devices, newer devices, Novati, it only contains silver core, remember that. In hormones, progesterone, LNG-20 or Mirena, both were T-shaped devices. One was releasing 65 mcg and the other one was releasing 20 mcg. The failure rates were very low and it has threads. The lifespan is 1 year. Now we are moving on to the time of insertion of IUD. When is the best time for the insertion of this IUD? We see that during the menstruation or within the 10 days of the menstruation will be the best time for the insertion of the IUDs. The best time is within 5 days of menstruation, because during the 5 days after, like within the 5 days of menstruation, the cervical canal opens, because all the during menstruation what happens, all the endometrium wear and tears off, and it is it comes out via the menses. The blood and everything comes out, so we see that the cervical canal, for the expulsion of all those contents, it opens up. Once the cervical canal opens, it will be easy for the physician to insert the IUDs. So the insertion, the best time will be within 5 days of menstruation. Why? Logically, it is because the cervical canal opens during the time of menstruation. Immediate the postpartum insertion, immediately after the delivery, during the first week after delivery, before the woman leaves the hospital, just because the woman has delivered the baby, the cervix opens to up to 10 centimeters and above. So the 10 centimeters dilatation will be there for the puerperal period. Since the cervix to come back to its original time, size, it takes time. During that time, the cervical canal will be quite wide and it will be very easy to insert the IUDs again. So we see that the post puerperal insertion is good and the postpartum insertion is also good. In the post puerperal period, wherein all the uterine changes are coming back to their original state, 6 to 8 weeks after the delivery, it is very good. So we see that what are the things, guys. Let us revise again. That is within the first 5 days of menses, 5 days, okay, during the 5 days of menses, and during the first week after delivery. In menses we have 5 days, during the delivery first week, okay, within the first week or during the first week of the delivery, before the woman leaves the hospital. Then post puerperal period, that is 6 to 8 weeks, okay, that is 1.5 to 2 months. Within the 1.5 to 2 months of delivery, go for the IUD insertion. That will be the best time. Fertility will return within 1 year in 75% of the users after the removal of IUDs. So now most of the patients will come and ask you this question. What are the side effects? Is it is it possible for me to gain back my fertility after the removal of this IUD? Will it have side effects? Is it possible for me? So we see that 70% of the users are gaining back their fertility within the period of 1 year. So we can see here the IUD's insertion has been shown very beautifully here. We have horizontal arm and the vertical arm, and we get this thing, okay, it's like this. We have a rod, and then the insertion pipe wherein the IUD will be kept, and now this IUD will be fixed here and it is inserted. Once it's insert, automatically it opens, okay, it like a umbrella. Once it goes, and once this point reaches here, the cervix, once it touches here, it opens up like an umbrella, and the IUD will be inserted and the tail will be in the vagina. So we see that what is given. We have insertion tube, we have this flank, these threads, and the solid rod, wherein when we see it in the the packet, we have this rod and we have this tube and the IUD, and the tube contains a flank which goes and fix, and the IUD opens up. So I hope the time of insertion and everything, how it is inserted and how it looks is clear. Now we are moving on to the mechanism of action of IUDs. Now once the IUD is placed in the body, what is the action it does in the body? In cases of copper, it will enhance the cellular response in the endometrium, and also it will affect the enzymes in the uterus. Remember guys, it has to prevent the pregnancy from occurring. So once it enters the body, what does it do? The mechanism of action, we see that it will act as a foreign body. Once it enters, obviously this metal and this hormone, the plastic, polythene and all, these are all foreign materials, foreign bodies which are showing a reaction in the uterus. Because of this foreign body reaction, the uterus will start to show such chemical, biochemical and cellular changes in the endometrium, and also the uterine fluids will be released, and these changes impair the viability of this gamete and they will reduce the chances of fertilization. Rather than its implantation, once this fertilization occurs and implantation occurs, rather than the implantation, the main thing is they will impair the viability of the gamete. The capacity of the gamete to live itself is reduced or killed. So the gamete dies. It reduces its chances of fertilization by impairing the viability of the gamete. Okay, it also affects the sperm's motility and also its survival. That is the action of the coppers. Now we see that this medicated IUDs, they also produce the local effects which will also add on to the contraceptive action, the local effects, that is irritation, inflammation and everything in the uterus. Because of the irritation, the fluids will be secreted, inflammation occurs there. It acts as a foreign body. So this copper seem to enhance the cellular responses in the endometrium. It also affects the enzymes in the uterus. By this altering the biochemical composition of the cervical mucus, these copper ions will affect the sperm's motility, the capacitation of the sperm, and also the survival of the sperm is reduced, very enhancedly reduced. Now we're moving on to the hormonal releasing devices. In the hormone releasing devices, how do they act? What is the mechanism of hormone devising, hormone releasing? Now we saw copper, it will go there, it will produce cellular changes, it will impair the viability, the living capacity of the sperm, it will kill off the motility, the moving capacity, and also the survival of the sperm is completely destroyed. Now this hormone releasing, what do they do in the body? They will decrease the they will increase the viscosity of the cervical mucus. We know that the cervical mucus should contain a particular pH, and the viscosity, the thin and thick and everything, all such things have to be very comfortable for the sperm to move up into the uterus so that the fertilization can occur. But then here what they are doing, they are impairing the viscosity. By what? The cervical mucus, they will increase the viscosity of cervical mucus. Once the viscosity of the cervical mucus increases, this will prevent the sperm from entering the cervix. They will also maintain the high levels of the progesterone in the endometrium. Thus, there will be very less estrogen. Once the progesterone level is too high, the estrogen level will be very low. Hence, the endometrium will be very unfavorable for implantation. So, the estrogen level, we see that estrogen level will be very low. We have the estrogen level very low. Whereas this the progesterone level, this progesterone, let us draw it like a demon. This progesterone level is very high. So this progesterone level, now in the endometrium, now let us see what happens in the uterus. This hormone releasing, in the first place, this the cervical, okay, in the cervical mucus itself, they are increasing the viscosity. In the cervical mucus, the viscosity is impaired. Once the viscosity is impaired, this sperm cannot enter into the uterus for the fertilization to occur. What happens next? When the fertility is impaired, in the second place, the hormonal changes. They keep releasing progesterone. So the progesterone goes high, estrogen goes low. Hence, implantation will not occur, and thereby it will prevent the pregnancy. So we are very clear what it does. And also we saw the foreign body reactions, the biochemical cellular changes, they will impair the viability of gamete, they will reduce the chance of fertilization. So in the pre-PG examination, if all of these come and this option is given, so the best answer would be to reduces the chances of fertilization. You need to select this option. What is the foreign body reaction, or what is the reaction of these hormones? They will reduce the chance of fertilization. Moving on to the ideal candidate for IUD. Now who is an ideal candidate for the IUDs? Who are born at least one child. So the woman who has given birth to at least one child, she is ideal, and who have no history of any pelvic diseases, who has her normal periods, and she's willing to check the IUD tail regularly. She has to keep a track on the tail. If it is sensed in her vagina, she needs to keep a track of her tail, and no of the IUD's tail, and there should be no history of pelvic diseases like we said, and the normal menses. IUD will be used as an ideal contraceptive for the lactating women, because it will have no effect on the quality or the composition of the breast milk. So it is highly recommended in lactating women. Also, she should have an access to the follow-up and treatment of the potential problems. If any potential problems come up, she should have the access for the treatment, and she should possess and like for the follow-ups and all, she have to have the ability to come. And then it is also used in monogamous relationships. Now, these were an ideal women or the ideal IUD candidates. Moving on to the next thing, we have the non-contraceptive benefits of IUDs. These were the normal benefits. We had many advantages, that these IUDs are very simple and everything. Also, we'll study in detail the advantages. So in the advantages, we have the simplicity, that is, it is very simple in insertion, and it only takes some few minutes for it to insert. And we also saw the duration, like in Copperties, 10 years, I'm really sorry, 10 years and 1 year in the hormone releasing. So the insertion takes just a few minutes, but you see the contraceptive effect. Now we saw the barrier methods. Every time a new barrier method, new condom has to be used, the disposal has to be done immediately. It should not stay in the body for more than 6 hours. If it stays, like shock syndrome and all starts. So all such thing we saw. But whereas in this, the advantages of intrauterine devices is it is very simple for insertion. It takes just few minutes for insertion. Let's have a picture of IUDs and discuss about it. So it's very simple. You can see the insertion is very simple, taking only few minutes. The effects are also reversible. 70% users have got the reversibility of their fertility. And the side effects as compared to the hormonal pills is completely free here. No side effects as compared to the hormonal pills. And like as compared, okay, there is no need for the continual motivation to take. Just like in pills, we need to continuously motivate the woman to take pills or use a barrier method consistently. Only one single act of motivation. Now after her delivery, soon after her delivery, one motivational like push is enough for her. She will take the contraceptive and the effect will last for a period of 10 years. So we see that however, they will have some side effects like heavy menstruation, but for now the advantages we saw is simple to use, insertion few minutes, long lasting, the reversibility rates is good. Moving on to the usefulness, that is non-contraceptive. Non-contraceptive benefits are known. We can remember it with HEMA, okay, HEMA, A, okay, A cube, HEMA. Now H stands for hormone replacement therapy, and we have endometrial cancer. They are useful in such cases, in which all cases IUDs are useful. In cases of endometrial cancer, in cases of hormonal replacement therapy, in menorrhagia, menorrhagia, yeah, in menorrhagia where there is heavy menstruation, IUDs can be used. In Asherman's syndrome, anemia, and adjuvant therapy for tamoxifen. In cases of these, the adjuvant therapy for tamoxifen and hormone replacement therapy in endometrial cancers, in the hormone replacement therapy where progesterone is required in the body. If they want some contraceptive wherein the progesterone is released every day at the rate of certain level, so that the hormone can be maintained in the body, the hormone replacement therapies in cancers, menorrhagia, Asherman syndrome, anemia, and adjuvant therapy to tamoxifen, we have the IUDs playing a important role. So these are the non-contraceptive benefits. So the normal benefits we saw, the advantages. We also saw the non-hormonal, non-IUDL IUD benefits. So next we are moving on to adverse effects. Now what are the adverse effects of these IUDs? In the first place, we have bleeding. You know, the most commonest complaint of women who is fitted with IUDs, it could be inert IUD or a medicated IUD, they come up with the increased vaginal bleeding. Comparatively, in the first generation IUDs, it is more. Then comes the second generation, then comes the third generation. In the first generation, it is high. The side effects of IUD, the bleeding is quite high. So we see that because of this bleeding, 10 to 20% of the IUD removal accounts for bleeding. The bleeding will take one or more of the following forms. We have the greater volume of the blood loss during the menses. Now, how does the bleeding occur? During menses, there is greater amount of flow. In the first place, the amount of flow during menses increases. We have longer menstrual periods. We also have mid-cycle bleeding. The the duration of menses is increased, and also mid-cycle bleeding is also observed. From the women's point of view, we see that irregular bleeding will constitute to the personal inconveniences will be there. Also from the medical point of view, we see they can result in iron deficiency anemia in a woman. Usually when the bleeding will be spotted in between periods, the patient will experience this iron deficiencies anemia, wherein because of the blood loss in between mid cycles, because of the increased blood loss apart from the menstruation, they will end up with iron deficiency anemia, and they receive the iron tablets. We give ferrous sulfate 200 mg 3 times a day to them. So we see that the copper seems to cause the blood loss. Now we have the uterine perforation. So this was the first thing, that is bleeding. The second, okay, before going to uterine perforation, now we move on to the pain. Regarding the pain, guys, which is a second major side effect which is leading to the IUD removal, we see that the pain, the most common leading removal of IUDs, that is 15 to 40%. Okay, in this, the pain is itself manifesting in the form of low backache, the cramps in the lower abdomen. So the women will come up with low backache or the cramps which are felt in the lower abdomen. Occasionally the pain will travel down to the thighs. These symptoms will disappear by the third month of the IUD insertion. So regarding the pain, we see the slight pain will also be felt during insertion, but it can be controlled with the use of analgesics like aspirin and codeine. If in case the pain becomes intolerable, the IUD should be removed. In place of a Lippes loop, a copper device can be tried. Okay, in cases of pain, in cases of Lippes loop, when the Lippes loop insertion is done, if the pain is very severe, go with copper devices, the pain will comparatively be less. So now we have uterine perforation. So now, so far what did we see? First one was bleeding and the second one was pain. Okay, the second one was pain. Now imagine the insertion, it is done at a wrong point, or it is inserted, it is embedded in the myometrium, right? Sometimes if it is perforated too much insertion, extra insertion is done, it can perforate off, it can create perforation, is what, making a hole, right? So basically what happens, you have inserted the IUD so deep that it has embedded inside the myometrium and then perforating, it has created a hole and the bleeding is there. So you can remember the three of the points together, you can remember there is bleeding because of the insertion, now it has perforated, obviously there will be pain and perforation. Bleeding, pain, perforation. Simple, guys. Bleeding, pain, perforation. Three things are done. Pelvic infection. Now once there is a perforation, obviously once there is perforation, we are expecting for the infection to occur at that point. So we have pelvic infections. The pelvic infections, the pelvic inflammatory devices, you know, it's a very long, it is a broad collective term. We include both acute, subacute, chronic conditions. The pelvic inflammatory diseases includes the tubes, ovaries, uterus, connective tissues, the peritoneum, and usually the result of infection we can see in all these places. Now here the pelvic inflammatory diseases we have already studied in our OBG, pelvic inflammatory diseases, wherein the ovaries, fallopian tubes and all these parts will be involved, and the infection can be caused by this organisms which are causing this infection is Gardnerella, anaerobic streptococci, bacteroids, coliform bacilli, actinomyces. The risk of PID will appear in the first few months after the IUD insertion. Usually it is in the first few months of insertion. Then it also has a chance of causing ectopic pregnancy. So now we can create a story in the form of a story we can remember. So a patient has come to your clinic. Okay, she was happy, she came to your clinic. Now she wanted to get a IUD inserted and you made her all sad. Why did she become sad? It is because the IUD was inserted way too deep. It created a hole. So what all did we see? There was pain. First, because of the hole, there was bleeding. In the first place, bleeding. Second, there was pain. Why pain? Because there was a perforation. Once the perforation happened, the third one was perforation. This was pain and this was bleeding. The fourth thing we saw that after the perforation there will be infections. Infections which were caused by Gardnerella, anaerobic streptococci, coliform bacilli, bacteroids, actinomyces, all these we saw infection. Then because of the infection there is a scar mark. So we know that on the scars there is a high chance that ectopic pregnancies can occur wherever there are scars, which led to ectopic pregnancy in that women. So we see that the uterine pregnancies which are occurring with the devices in situ, in such cases they will result in abortion. Now since that was an ectopic pregnancy, the IUD was still inside her body. So the IUD was still there in the uterus and the pregnancy also occurred. Since the pregnancy with the IUDs is occurring in situ, either there will be spontaneous abortion, or if she wants to continue the abortion, if the thread is still visible, just remove the IUD. If the thread is visible, just pull it out. If the thread is not visible, without any without any help, helplessly, we have to evacuate the uterus. So very sadly, what happened? A woman came, you inserted the IUD, there was perforation, there was bleeding, pain, perforation, and because then the perforation led to infection, then the ectopic pregnancy occurred. Ectopic pregnancy, if it is in situ with IUD, ectopic pregnancy is the first point. Next, the pregnancy is occurring with IUD. We have two options now. Now the pregnancy has occurred with IUD. The two options: one, either abort it or abort the baby. First thing, if there is the thread is still visible in the vagina, just pull it out and continue the pregnancy. If the thread is not visible, then we have to evacuate the uterus. I hope it is clear. If they ask the adverse effects, you should be able to list them out. What are the contraindications of IUDs? So what are those cases wherein the IUDs are not encouraged? Guys, along with these adverse effects, we also have the cancer and tetragenic effect. So far, there is no evidence to date that IUDs have increased the cancer risk, but still there is a certain articles and things that there is some cancer and tetragenic effects of these, and the mortalities associated with IUD will be very rare. Okay, 1 in 1 lakh. So we know that the mortality out of it is very less, and the expulsions will be either partial or complete. If there is partial expulsion, we need to examine it using the speculum, and the stem of the IUDs which is protruding to the cervix, we have to just remove it. Okay, this is in cases of other adverse effects, not very important. These are the most important ones. This cancer tetragenic effect, you can just like in your exams, university exams, you can just mention a point. It's not much known so far, and also the expulsion rate is very high. Mortality is very low. The mortality we see that is completely low, 1 in 1 lakh. Moving on to the contraindications, we have vaginal bleeding, CA cervix of CA uterus, pelvic tumors. So we can remember the adverse effects and contraindications together. If the adverse effect was bleeding, so a woman is having vaginal bleeding, it is contraindicated. Pain is an adverse effect. So in the nulliparous women, when you insert it, there will be increased pain. Okay, because the cervical canal, she has not delivered any baby, so the dilatation of the cervix will be is not possible in them. It's very difficult. So it will be increased pain. So contraindication, nulliparous women. So this way you can remember: bleeding, contraindication, vaginal bleeding; adverse effect, pain in nulliparous women. So it is contraindicated in nulliparous women. Uterine perforations. So this can lead to CA cervix, uterus, pelvic tumors. If there is uterine perforation in cases of cancer, this from the uterus, like the malignancy can enter into the bladder in the front and rectum in the back. So we have urinary bladder in the front, right, and rectum posteriorly. So it can enter into the adjacent organs. So it is not encouraged in cases of CA. The uterine perforations can occur. So in CA cervix, uterus, and in cases of pelvic tumors, it is contraindicated. In cases of pelvic inflammatory diseases, it is contraindicated. In ectopic pregnancy, which is an adverse effect, you can remember that even in the previous ectopic pregnancy, when you take the history, if the woman says that she had a previous ectopic pregnancy and she had to abort the baby, so the contraception is contraindicated in her. Pregnancy with contraception of what? Intrauterine contraception is contraindicated. Other contraceptives you can opt for her. Pregnancy with IUDs in situ. Suspected pregnancy and after second trimester abortion, it is contraindicated. If she is suspected of pregnancy, if she is suspected that she is pregnant, after the second trimester abortions, it is contraindicated. The expulsion, so the adverse effect we saw was an expulsion, and women with multiple partners, the expulsion rate will be high in her, so it is contraindicated in cases of multiple partners. Women with multiple partners, it is contraindicated. So we see that IUD is not a method of first choice for the nulliparous women. In nulliparous women, it's not the first choice. Cervical canal dilatation and all, so it will cause a lot of pain, and the fertility rate is just 70%. So nulliparous women, it is not encouraged. It is not recommended for women with multiple partners, because in such women the sexually transmitted diseases, pelvic inflammatory diseases, and possible infertility is seen. Not recommended after the second trimester abortion. Once there is second trimester abortions, then it is not indicated. Okay, so these were the contraindications. With this we complete the IUDs in detail. I hope everything is clear. If you have any doubts, put it in the comment section, and if you like my video, hit the like button and subscribe.